It is a great honor to me to be with you in this party today and the day of acute kidney injury second day module. To be honest, I was very happy when Dr. Saad asked me to be a moderator here in the last moment, as Dr. Saad would have commented. Just to get the honor, if you are here sharing here, if you are in whatever you are a candidate or moderator or a speaker, and thanks for Mega Medical Association. And the first speaker for today party, Dr. Emad Elkholy. His major part and the important part of our medical and clinical machine. Without him, the machine will stop. Our eyes and the guidance for choice of the drug, dosing, preparation in his clinical pharmacy. Dr. Elkholy was graduated from Helwan University, Egypt, got his higher credential and postgraduate training from Beni Suef University, Egypt, as a board-certified pharmacist in pharmacotherapy, in critical care and cardiology. Currently, he's working as a cardiology and critical care pharmacist in King Abdulla Medical City, Holy Capital in Makkah, Saudi Arabia. Dr. Emad will guide us today for drug choice dosing in acute kidney injury. The seater for you, Dr. Emad. Can start.
I'm very happy. I'm very honored actually to be with these great consultants and the great people of ICU. Indeed, today I'm not coming to solve issues. I'm coming just to ask questions. And indeed, it's a very crucial questions we are meeting every day in our practice in taking care of critical care patients. So basically, I'm talking about dosing in AKI and CRRT, and most probably I will focusing on AKI. My question simply is, are we dosing enough? And we will go together to see what I mean with that. So first, I have nothing to disclose. I'm going to start firstly with very basic information for everyone. I think no doubt about those information that AKI has a very high mortality rate approaching 50%. And this AKI, if we have this study from a multi-center study that showed that we have a very high mortality rate from AKI resulting from septic shock. We are talking about odds ratio about 1.7 to 2. And if it's gonna be septic AKI, we have 5-fold increase in mortality. So this is a very big issue. Usually we are saying that AKI is the cause. And to a great extent, this is correct, but let me explore another scope today with you. Okay, so we can say that septic AKI is common during the 24 hours after ICU admission, and also septic AKI during the first 24 hours after ICU admission. They are generally sicker and with high burden of illness. Moreover, septic AKI is independently associated with higher odds of death and longer duration of hospitalization. So the question raised very early, 20 years later, that if inadequate antimicrobial treatment is a risk factor for our critical ill patients, and this was repeatedly every time in ICU population and generally in AKI patient, especially that we have subtherapeutic, usually initial beta-lactam concentration in selected critically ill patients. This was confirmed in the DALI study, the well-known study about the antibiotic dosing or levels in the ICU. So if we see generally, this is from the DALI study, that we track the failure rate of generally antibiotic dosing. We can see here that, as example, we have very high rates of achieving in some antibiotics, but on the other sides, we have very low rates of achieving the required doses. So, in the context of the the well-known 1 hour bundle. Usually we have some sort of, we need to give appropriate antibiotic for the patient in the 1 hour septic bundle. Of course, it's debatable and there's a lot of debates about this issue, but we are just exploring what is the appropriate dosing in regards in terms of pharmacokinetic and pharmacodynamic. So what is the general ideas I tried to say? That the mortality rate in the critical care patients from sepsis is reported to be from 20 to 60%, that inappropriate antibiotic therapy in patients with sepsis in the ICU is prevalent and is most important dependent risk factor for hospital mortality. Primary reasons for inappropriate antibiotic therapy has been identified as antibiotic resistance and absence of efficacy therapy in most studies. Pathogens are susceptible to prescribed antibiotics, hospital mortality still remain high, and doses sufficient to deliver antibiotics concentration at the site of infection. So we have to know that the FDA recommended Cockcroft and Gout equation, and this is well known to the pharmacokinetic clinical trials, but we have to go with this event timeline. What we are saying here that the pharmacokinetic era started in the 60s actually, and in the 70s, regulatory guidance started to evolve to guide us regarding dosing in antibiotics. In 90s, we have these clinical initiated post-marketing studies mainly. It was not by agencies, mainly by clinician-led. And we have in 2011, the KDIGO guidelines, which was developing more questions than answers regarding dosing in AKI. So we don't know what we have in the future. So this is simply the KDIGO guidelines. It's very well known 10 years back. It was not updated yet. It was telling us that what we know in the AKI dosing is very, very small amount of ideas. It was mainly focusing on all four focuses in impact of renal function on drug disposition and response, patient assessment of drug dosing, calculating drug doses in AKI and CKD, drug removal by intermittent and CRRT. And what was clearly at that time that it said that to us, it informed every one of us that FDA and EMA, they are making this for chronic kidney disease patients, not our critical ill patient with AKI. So let us remember this idea. And after that, we have this expert consensus document. It was published in 2017. It was very nice telling us that really we have most of our patient recovery within 48 to 70 hours when they are presenting to our facilities. And one of the very interesting consensus it gave us, it's saying that we have to measure urine creatinine clearance, which is very harsh for everyone to do. It's not very easy, especially on those days with these COVID complications. We are trying to decrease nursing and every contact to the patient in real day life. And he is telling us the equation to estimate GFR rates in the setting of chronic kidney disease are not accurate for assessment of renal function patients persistent AKI. So this is the second information. For this point, I can make a whole lecture going through all different calculations and what is overestimating, what underestimating, but I will not be busying you with this, but indeed, we have very limited ability to dose. So it's a very nice recommendation. I advise everyone who has never been to this recommendation before to go through it. And it's giving us a very nice stepwise approach that we should obtain history and relevant demographics for the patient clinical information. This is mainly to remove any nephrotoxic medication. He's telling us to estimate the GFR. And as we said before, later on they put the 24 urine collection as a golden standard, which is very difficult to review current medication for the patient, calculate individualized treatment, and this is what we are all talking about today. So this is our patient, a very classical patient coming to our ER. Weight is 95 kilograms, age 68 years old with abdominal pain, altered mental status. And we have a beta-lactamase positive Escherichia coli in neurosepsis. And the intensive care unit, he which had not received empiric antibiotic but did not get aggressive fluid resuscitation, the emergency department, the patient oxygen saturation dropped rapidly and developed respiratory failure and septic shock, required mechanical ventilation and vasopressor symptoms. So regarding his lab, that's about 2.2 from baseline, 1.5. We are lucky to know the baseline for the patient. Sometimes we do not. And the patient weight in the nursing home chart 1 week ago, it was 80 kilograms. Susceptibility results are pending. The ICU team not to prescribe antibiotics. So my question is, what antibiotic you will be really concerned about in this patient? I would be happy if we have any responses. Okay. See the chat. Colistin. Okay. Any ideas? Any other ideas? Colistin and vancomycin. Okay. Sam, Dr. Sam. We would be happy if we have more share. Let's open talk, no problem. A, vancomycin. Okay. So we have 4 or 5 responses. It's around the colistin, vancomycin. Okay. Okay. So we will see. We will go together and see what maybe will be really a concern in such a patient. So, okay. So it's a very quick reference that not all antibiotics is working equally. We have some antibiotics we need to make sure that we have a very high level initially. Some medications we are required to make sure that it's above the minimum inhibitory concentration for the microbes, which is rising day by day for our drug abuse. So this time may be crucial for other antibiotics like beta-lactams and carbapenems as examples, and EUC-MIC is a mixed mode between the 2 of them, which is like vancomycin as example. So it's very basically known to everyone that we have to achieve plasma concentration at target site concentration to achieve a pharmacological effect. So what are the factors going to affect our dosing in this critical ill patient? If the patient is going to have a dialysis, of course, the drug removal is going to be highly affected. The patient size, and this is very underestimated issue. We have a patient with 95 kilograms. It's not like the 70 kilograms. This is one issue. The second issue, if you noticed in this patient, we said that patient was 80 kilograms and his coming weight is 95. So he's acquiring more than 15 kilograms during a week. So this is maybe, of course, not fluid, but yeah, we have a good amount of this is regarding to fluid. So of course, antimicrobial factors, susceptibility, drug interactions, all of this is going to affect our ideas about the dosing. But my question is, and this is not my question, so this question has been asking for 10 years now, are we making dose reductions always necessary? If it's necessary, this is the first question I'm gonna think with you today about. So for this study conclusion or this review conclusion, he concluded that antimicrobial dosing in critical ill septic patients with AKI challenging as antimicrobial clearances are frequently decreased. For many antimicrobial interpatient variability appears to be substantial, making it difficult, if not impossible, to predict adequate dosing needs for all patients with severe sepsis and septic shock. As standard doses in critical care, patients without AKI frequently fail to achieve target PK target. Dose reductions may not always be necessary, especially in the first 24 to 48 hours. The same concept was published in 2016, and this guy, you have to read his parts. He has really a very nice pieces in drug dosing in critically ill patients. He has more than 35 years experience and a lot of applications in regards to this regards for this issue. So he has this, we can say it's a very nice article about we need to give enough antibiotics, especially in AKI. And I will tell you what is the concept maybe he's taking. Here we have a comparison why we should give a lower doses and why we should give a higher doses. So for lower doses, of course, we need to have very concerns about antibiotic toxicities. We have decreased renal clearance, of course, definitely. We cannot measure accurately. And we have, of course, reducing unnecessary costs for drug. And on the other hand, why we might need higher doses, especially in the first initial assessment with patients, we have retained renal clearance, what we call residual kidney function, adequate concentration at target site, especially the difficult site to treat, like bacteremia, like maybe pneumonia, extracorporeal drug clearance if we are using CRRT, increased antibacterial resistance, increased volume of distribution, and decreased protein binding. So you have to watch out. When you are assessing a creatinine for a patient for 24 hours, you cannot depend on just one single reading. There is a lot of issues you have to take in consideration. It's not all about numbers. So here we like the volume of distribution on those patients. Although this is about gentamicin, it's showing that we have maybe a double volume of distribution. That means that if you are giving a patient with no sepsis a dose, your volume of distribution may be a double in a septic patient with AKI. And here's Dr. Muller recommendation. He recommends that we use for time-dependent recommendation like beta-lactams, carbapenems, we should use continuous or at least prolonged infusion. In carbapenems, we have to use more frequent administration of small doses. And for vancomycin, he advised us to give supplemental dose during prolonged intermittent renal replacement therapy or post-hemodialysis, and of course to use weight-based dosing. And for the concentration dependent, he advised us to use weight-based dosing, of course, and same for daptomycin. And for aminoglycosides, which is, of course, it's not gonna to be easy to use, although we sometimes use colistin for band drug resistance. Unfortunately, we are facing everything. So we can have, I think, three steps. First, you have to give a very good loading dose, especially from beta-lactams, cephalosporins, and carbapenems. You have to be very aggressive in loading dose. What I mean by aggressive loading dose, I'm gonna to show you some nice data. And for the maintenance, it's all about clinical judgment. If you are gonna to continue, please make clear observation about is my patient AKI is going to resolve? This would be a very important question to decide this dosing. You cannot tell I'm giving this dose for 7 days or 5 days or 3 days. I think maximally you can give 1 day and check after that. So I will show also what I mean. You should be initiated a normal or near normal dosage regimen. And of course, therapeutic drug monitoring for drugs that we can or we are able to monitor. It's highly recommended that we do TDM. The same, Dr. Muller again, he is telling us in renal dosing of antibiotics, are we jumping the gun? There were very concerned regarding the new antibiotics, ceftriaxone, ceftazidime, avibactam, and telvacin, that we have a reduced clinical response in patients with estimated creatinine clearance from 30 to 50. And this is a really concern that is going to face us in the future. They are not saviors. We will face what the same we are facing now. So, and in this study, actually, he did a very nice registry for around 18,000 patients, and it was checking after how long we gonna to have improved kidney function. So if you can see here that we have two population, if we have in this curve, if you have the fractional changes in serum creatinine above 2, unlikely that your kidney function is gonna to come back to normal. But in those models, if you have from 1 to 1.5 fractional changes in creatinine, mostly of the patients gonna to come back to normal in 48 hours. So this summary also renal dose adjustment are determined in healthy subjects with chronic kidney disease. Empirical antibiotic dose reduction for renal impairment in trials and the practice may frequently be premature due to high prevalence of transient acute kidney injury in affected population. So I will run for those pieces very quickly. Again, subtherapeutic initial beta-lactamase and critical ill patient, the DALI trial, we pharmacokinetic of meropenem in critical ill patient with severe infection. And because of that, we have a very nice randomized clinical trial in 2008 that was comparing the continuous infusion with the bolus infusion in attainment of the beta-lactam or meropenem levels. And of course, it's pharmacokinetic study, it's a very small study, but still you can see here that with the continuous infusion, we had a good time above the MIC. However, in the 1 gram acute 12 hours, it was quite different. And this is a very nice, very early published in 22 in Iran. And this patient, although this study has a lot of flaws actually in the design, but what I wanted to share with you the conclusion of this trial, that in critically ill patients with AKI, those not received renal replacement therapy, standard doses and adjusted according to renal function of meropenem failed to achieve the PD pharmacodynamic target, and they recommended higher doses are required for this stage. It was studying meropenem, and especially meropenem 500 PID was extremely failing on those patients in regards to other doses, in regardless of the creatinine clearance issue because it was incorrectly measured. But I'm talking about the dosing itself. And even though in this study, I think they recommended around 6 grams, however, their work does not qualify them to give this recommendation. So here we are going to go for some recommendations. I was talking about that you have a lot of reference actually to use. So here, one of the very widely accepted references is giving you this recommendation of 500 milligrams Q12 hours for patient from 10 to 20 renal estimate, and again 500 Q12 hours. Again, this is alternative 1 gram Q12 hours, and this is for Lexi the same. It depends on what dose you are considering in the first, so you are able to give 500 or either 1 gram at least. So I think this is much more appropriate. And this is a recommendation from the KDIGO guidelines. It's not to avoiding Stanford exactly, actually, but what it was saying that you have to avoid this wide range of dosing regimens. You cannot treat a patient with 49 ml per minute like 11 or 10 or 9. This is completely a flaw. So we are recommending not using this very large, using this narrow intervals is way better to achieve those levels. So here we are about CRRT. I will not take too much about CRRT. I think I have maybe a couple of minutes remaining. So CRRT is well known to have the 4 modalities of CRRT. What the dependent factor, the molecular weight, hydrophilicity, lipophilicity, protein binding, volume of distribution, clearance pathway. So of course the blood flow is different, dialysis flow is different, ultrafiltration sometimes there, sometimes not, and the solid removal maybe with any of those methods, which of course affecting our drug elimination. So antibiotic dosing in critical ill patients receiving a CRRT underdosing is over prevalent. This is just a question. It was published in 23, I think, also for Prosmiller, and he's giving us a pearls. He's telling us about that the degree of pharmacokinetic alteration in critical ill patients is different than in the stage, that one size fits all is not a good strategy. The influence of RRT dosing and intensity must be taken into account. What we call this is, yes, the CRRT dose, review primary literature, and don't forget that patients sometimes have some residual kidney function. So you will find in the CRRT, again, a whole of very high differences in dosing regimen. So yes, it needs to be very picky. So in CRT, especially, every time I ask me a question, a couple of questions actually, of the last CRT patients you treated, how many except signs and symptoms of received too much antibiotics, and how many patients die of infection? This is a very important question indeed. And this is comparing a different dialysis and alternative filtrate production rates, which is making differences in dosing we have to adjust for. And this is one of the challenging to adjust in CRT indeed. We have very complicated equations to use, but this is not implemented in the practice that too much. And lastly, I will finish with the colistin as example. It's have a very large molecule, and due to this data, it was previously in this well-known reference of CRRT dosing and CRRT. We are giving colistin. It's around 2.5 milligram to 48 hours. So this is what we used to do. But however, after new researchers, we have going up again and again because we have plenty of data. I'm not able to show because of the length of the lecture in regards to achieving the pharmacokinetic target. So we have around 300 milligram followed by 22 every 12 hours. So we are talking about around in million units, around 13 million units. And this was confirmed by the this consensus regarding the dosing of colistin, and this is the lexicon recommendation. It's a very updated source. Whatever you have, use it, but make sure that it's quietly updated. So my message is simply as assess your patients, not labs. Give a loading dose, reassess, give a good maintenance dose, aim high, and not one fit all. Use different resources. Don't rely on one resource regarding your dosing. And thank you. And I'm open for any questions.
Thank you, Dr. Emad, for this informative presentation. I like it and enjoy it.